All right, well, thanks for being a little bit flexible with me. And as I've described to some of you, this is going to be a crazy week. I'm flying back, and I'll be presenting this at the Arthroscopy Association in a few days. So the deltoid exam and arthroscopic repair, disclosures are about the same. So again, following Tom Clanton is very difficult because he wrote all these papers. But looking at the anatomy is something we need to understand before we do any type of surgical reconstruction on any level. So looking at his paper, understanding where the spring ligament and where the tibial spring ligament and the tibial navicular ligament, there are a lot of ligaments in here that we need to know their origin and insertion. And his foot and ankle, I think we're kind of cavalier sometimes about where we put our anchors. As my colleagues in here, the knee guys, they can talk about the tunnel placement ad nauseum, where it is and how many degrees. But in foot and ankle, we're like, yeah, that's close enough. We bang some anchors in. That's not appropriate. So knowing the anatomy is so important before we even start talking today. So this paper right here is really nice. This is LaPrade and Clanton's paper, looking at exactly where the footprint is of these ligaments. We need to know this before we go putting our anchors in at the wrong spot and tensioning it. We talk about the isometric point. So I'll draw your attention to the deep anterior tibial talar ligament, just right there, and there's a nice little bare spot right there when you look at this on a cadaver model or in the real surgical theater. I just said surgical theater, didn't I? That's funny. And so looking at this, now looking at the deep layer right there is the same location. So you have that deep anterior tibial talar ligament. And that's what we're going to be kind of focusing on today, and I think that's the key to the deltoid as we move forward. So you can't talk about the deltoid without talking about the syndesmosis. So by talking about the syndesmosis, we talked about a little bit the other day with Dr. Vega about where the Bassett's ligament is and how the AITFL actually has 3 bands associated with it. And you can see below the AITFL, then you have the ATFL and the CFL ligaments all combining to form this lateral ligament complex. And again, another LaPrade and Clanton paper, beautiful paper. This is what every resident should be reading. Before we go into the OR and try to reconstruct this, you have to know the anatomy. And this is where Dr. Vega made the point of having 2 bands of the ATFL. I'll argue that in reality, how often do I see 2 bands? I don't think ever, but it's some anatomy, they can show it. There are clinics in Barcelona. Somehow these guys can dissect the 2 of them out. I cannot hardly ever do that or see that. And then looking at another LaPrade and Clanton paper, looking at sometimes we talk about isolation and we talk about rotational injuries. Now these rotational injuries can be created if we only section the AITFL. So we have to keep that in mind as we're doing these procedures and as we're examining these patients with a scope. We have to know what injury causes what rotational component. So looking at the deltoid now, so Dan, Gus, and the guys and DiGiovanni, I got to present there last year. It was a nice program. They were a top-notch group. So they looked at how the deltoid affects the syndesmosis. And it really doesn't do much until you section the AITFL and the interosseous ligament. So this is not just one or the other. You have to have some on the medial and the lateral to get true disruption of the space. So understanding the medial constructs and the lateral constructs is so important to this whole workup. And then for years, we've been told that you don't have to fix the deltoid. Why would you fix the deltoid? And that's been kicked down to me for generation and generation. If you actually pull the papers were published in 1988 and 1986. And not to say that those aren't good papers, not that they can't stand the test of time, but if you actually get in the nitty-gritty, they use no functional outcome scores. Their outcomes were actually dismal, and they didn't track their patients very long at all. So looking at those as our paramount papers that make a decision what we do with our full paradigm, I think that's long gone. So looking at some more recent studies, their actual groups didn't do that much difference, but we know that in this paper they closed down the medial clear space by repairing it. And we know that a joint that is subluxed, especially in the talus, by a couple of millimeters, the joint reaction forces go through the moon. So by leaving a medial clear space wide, you're dooming this patient long term. So that's why the functional scores were so much higher when they repaired it. They restored anatomy. Again, restoring anatomy is key. And I believe fixing the deltoid contributes to that. Now the deltoid anatomy, this slide right here is controversial in itself. Because if you look at it, I say the superficial resists eversion and the deep resists external rotation. We've had a couple talks on deltoid and people have mentioned it briefly in their talks, and it was exact opposite to this. Twice I heard the exact opposite of this. Because even the papers that we have that tell us what affects, they're not that accurate. We do not have good enough studies on deltoid right now. So if anyone wants to do a research study, we should be looking at some deltoid and actually taking some time and sectioning each little band and seeing how it goes and what that contributes to. You would think it's such a simple thing, but the deltoid's been underappreciated for so many years. And so now what I feel is so strongly is that by looking directly at it, that's how we That's how we diagnose a deltoid tear. This is me visualizing through the medial gutter using a nanoscope. With nanoscope, I feel like I can drive through the medial gutter further and see deeper and see things other people can't even appreciate when they look at this. Because a lot of people say, oh, the deltoid's fine. After I put a clamp across, and as Marcus pointed out yesterday, just put a bigger clamp. If you can't get it reduced, just put a bigger clamp and squeeze it down. There could be something in the gutter, or you could be missing this injury. And then on the right, this same patient, if we know the deltoid's out, we should expect to look at a syndesmosis and see the AITFL is also torn. So appreciating lateral and medial structures and how they work together and using the scope to do that dynamic examination. So this paper is FAAOS is our academy paper. We use it as our kind of our structure of all things we kind of do. It says indication repairs, medial gutters blocked, dynamic instability, high energy, Weber sees. But the first line they put in the indications is that it remains controversial. So even their recommendations, we're like, hey, we're going to recommend it, but we don't know why, and it still may be controversial. So even in our papers that are supposed to guide us, they leave us kind of hanging of what we should actually do. And then we look at another paper that talks about Dr. Hinterman on this neck of the woods, looked at his process and the way he repaired his. And again, on this one, he used one suture anchor and only repaired the superficial layer. Okay, so he did not go deep on his paper. He did not go posterior. So he was superficial band only and with one anchor. Keep that in mind as we go forward. In my paper in JAOS a couple years ago, we kind of went through the workup and how we actually examine the syndesmosis and the step-by-step algorithm to examining a syndesmosis and deltoid injury. I think it's paramount to use the arthroscopy. The arthroscopy is how we do a dynamic examination. So we do our dorsiflexion, external rotation stress test. Do it when you're looking at it. You look at your drive-through sign, look at it. When you're doing it, these exams become something when you're looking at the tissue as you're stressing it. If you decide it's loose, the first thing for me, we talked about this the other day, is stabilizing the syndesmosis and reconstructing the intraosseous ligament with the button technique. So by drawing this down, I feel that really restores the coronal plane stability. But a lot of times you'll be left with this. So even after we put our tightrope in, I showed this yesterday briefly, but so again, this is going in, that's anterior lateral distal tibia, drilling, tapping, and placing a 475 swivel lock with a tape attached, going over to Wagstaff's tubercle, drilling, not tapping, and then putting our 3.5 over there. And I would argue again, like I did the other day, that this is as anatomic as you're going to get the AITFL. There's not more anatomic reconstruction than this. And that tape was brought up yesterday. That tape is not rubbing on the talus. You can see it there. We are clearly not restoring Bassett's. We are clearly restoring the middle or proximal band of the AITFL, not Bassett's ligament. We were able to publish that in the Foot and Ankle Technique Journal a few years ago with me and my partners. The Mercedes sign. We talked about this, Marcus and I, last night at dinner quite a bit. How do we know that it's restored? How do we know that we have the syndesmosis in its spot? Traumatologists often tell me they're looking at it when the open procedure. They're looking at it. I would argue that this view right here is the best view you're going to get of your syndesmosis. If you don't establish that nice Mercedes sign there, you are not anatomically restored. And I drive a Dodge Ram, so I don't have one of these, but I got to look around at your guys' parking lot and what that Mercedes sign looks like. But there we go. And this is what the post-op x-rays look like. So you get your tightrope in place, all percutaneous, flip the button, one stitch, and then your portals serve as your way to put in your AITFL reconstruction. So for my high-end athletes that want to be back on the football field at Ohio State in 2 weeks and get back and trying to hit people, this is what we're doing. Last year we had one of our players at 2.5 weeks. He hit 21 miles an hour running on the field. It's pretty crazy. He can still run 21 miles an hour a couple weeks after the surgery. Looking at the grades now. The grades really historically have been very poorly defined by arthroscopy. Dr. Hinterman has a paper from years ago. It's black and white pictures. You can't see a darn thing in the paper. It's really antiquated at this point. But looking at a grade 1, meaning the tip of the deltoid, more of an avulsion injury. What do we do with that one? So Bob Anderson and his group of the NFL talks about we go in and restore that and repair it with one suture anchor, sometimes two. Again, just the superficial layer. That's why I'm putting that in bold at the bottom. They did not go deep for these kind of athletes. They were just repairing the medial. And Bob's quoted multiple times as calling this just a medial brostrum. And I like that technique. I like that description. It kind of lets everybody know what you're doing over here. So let's look at the next one here. So dynamic examination again. So the lateral ligaments have been repaired. You still see the external rotation. See how the talus is externally rotating? And I can open up that medial gutter. So being able to open up that medial gutter and have that much dynamic examination is indicating enough for me to go after these. So for me, that's going to be using the scope and actually making a small you can see down here, making one additional small percutaneous incision. And then the knotless fiber tacks go in under direct arthroscopic visualization. One is placed at about the tip of the medial malleus, and one is about 6 millimeters proximal. And then Justin and I were talking about this. We were talking about how these anchors work. So I link the two fiber tacks together. And once you link the two together, it acts as, we call it a ripstop phenomenon. So you link the two fiber tacks and pull them down. And what that's doing is actually repairing the cuff. So on this one, now you can see I've shuttled both of them through. And now as we start to sequence and pull these, you can actually watch it restore the deltoid back to the medial malleolus. So for my grade 1s, that's what they're getting. They're getting a percutaneous repair with two knotless fiber tacks that restores it back down to bone very nicely. But let's look at what I'd call a grade 2. Now you can see it's a much more severe injury. The injury goes back, I would call it past the 50-yard line in the football term, but we're into the incisura groove back there. And we also look at the Guyton ball. It's a 3 millimeter probe out of the Arthrex kit. The syndesmosis is clearly disrupted, clearly a complex injury. And now one of my favorite tests to do in the left here is the fibular translation test. Oftentimes we talk about the cotton test, and we can only pull it in the coronal plane. I think the sagittal plane is far underappreciated in how much that rotation, how much that A to P shuck actually is involved, and that's why I think the AITFL alone is oftentimes injured per that paper we talked about that Clanton had written earlier. And now switching over, now we're looking directly at the syndesmosis, that's talus, distal tibia, and fibula, and we can see how this reacts with a dynamic dorsiflexion external rotation stress test. We'll see that here. So now I'm dynamically stressing it, and I would argue that is not reduced. That is not a good syndesmosis right there, and that is clearly unstable and clearly unacceptable for our patients. So what do we do? I take these a little bit more serious, and I do my same two fiber tacks, but I do an open incision, and I do the same fiber link where I link them together, pull up that whole cuff, restoring it as you'll see here. So again, these knotless anchors to me are the way to go. It allows me to pull these up, restore the anatomy, and have a knotless system. That's what's beautiful about this. But why do I do this for 2s and not for 1s, and why do I upgrade it? Because now I feel like that if you see the cuff, kind of a tissue of deltoid here and periosteum there, then I can take some vicryl and I can imbricate them and do a second layer repair, a little bit stouter repair in my mind. Again, I don't have any evidence behind this, but there's not a lot of good guidance out there for what to do with deltoids. So that 2 gets 1 step up for me in my hands. And I would argue that's reduced after the fact that gutters close down. And again, when you have a scope, pop it back in, check it out, see what you did. Did it work? Take a look before you leave. And then again, Dr. Anish Kadakia has a nice paper out here. He was actually doing bone tunnels, but again, I'm just emphasizing they were only restoring the superficial layer, which we've done in the 2 papers I've talked about and the 2 techniques that I've described. What about this one though? Who's seen this before? Has anybody scoped the medial gutter and seen the posterior tibial tendon before? That is bad. If I stick my scope in and I can see your posterior tibial tendon, there is nothing attached. Your deltoid is gone. Anterior, superficial, deep deltoid, it is gone. Everything is out. You go and you fix your fibula and you get this. How many of us check that at the end of the case? I would argue not many of us. I was not taught that in my training to finish a good case, finish a nice, nice case there. Is that your plate? I think that's your plate. That's a beautiful plate. So that's a nice plate right there. It's an Arthrex plate, of course, tightrope across. But that instability, you got to do something about that. You cannot leave this for this patient. So what do? This is where the internal brace gets involved. So now I open it up. You can see this deltoid is completely insufficient. It's completely avulsed off. It's still there, but it's just completely shredded. So now I go in, I elevate that periosteum, and you can see my freer going in there and aiming directly at that bare spot on the medial wall of the talus, the anatomic point. You can see right there with the big red arrow. I did the first several of these under fluoro. I still do them on fluoro just to make sure I'm as anatomic as I can be. This is one of the few times I use fluoro in my ligamentous cases. Drill, tap, put a 475 in the talus, and then run my sutures through the capsule. So again, I don't want the internal brace in the joint. I want an extra capsule. So I then take a free needle and pass it through the deep deltoid, and then pull it through. And you can see how unstable this ankle is once we kind of pull this through, and what kind of great control the talus that 475 gives us. And you can see how unstable this ankle is truly right there. You can reduce the whole thing with that, and that's why the internal brace to me is so paramount in these reconstructions. After that, now I've kind of switched from these slides, and I now use those 2 DX fiber tacks right there, so it's completely knotless. Again, one at the tip and one at about 6 or 8 millimeters. The internal brace goes directly between them. Again, just like the brostrum I described yesterday, same thing. Bob Anderson described it nice. It's a medial brostrum. 2 of those go in. The internal brace lays on top. Again, as a check ring, not overly tight because you can overly tighten these. So I kind of go to the laser line and just kind of use the laser line as my guide. Don't do anything too crazy. You can see I have the ankle in a neutral position. I don't have it plantar flex, dorsiflex. Just kind of maintaining that good neutral alignment. That's what it looks like when I'm done. Cut the excess suture, some Vicryl to clean up the whole thing. So you have a 3-layered deltoid repair, basically using the modified Brostrom approach. It's the same thing. And we were able to publish that paper in Foot and Ankle Techniques a few years ago as well, just describing this. And why I went to the suture tape with 2 anchors, again, because that's a grade 3 tear. That's everything is gone. I think that's when you step up to the internal brace, and that's when you need a little bit more extra force because the whole thing is completely gone at that point. And then also, this paper is also kind of an interesting look. Another Hinterman paper talking about arthroscopic direct examination demonstrated that deltoid ligament injuries occur up to 40% of ankle fractures, right? It's crazy. It's crazy high. How often do we look at that? We're not looking at it. We're ignoring this a lot of times. I think we need to be very eloquent and look at the deltoid when we're in there. Don't just kind of stick it in the gutter, look for the cartilage. Look and do a dynamic exam when we're in there so we know what to fix and then how to fix it. And then it wouldn't be a good talk if I think I'm the last talk today, right? Or I was. So thanks, I'm out of time and I'm moving out. This is me jumping in to just north of Florida on a training mission we did, I don't know, 2 years ago. But anyway, thanks for your time and I appreciate it and I hope you'll fix a deltoid.